Okay, so basically the supraspinatus job is to allow all the other muscles to work around. So if you have infraspinatus and subscap from the front and the back, and the teres minor helping the infraspinatus, when they pull, the humerus escapes to the top. Right, the job of the supraspinatus is to stop it from going up. Now that's why if you have a supraspinatus tear, you have a lot of problems. Now if the supraspinatus is just only doing abduction, then the deltoid also does abduction. So it wouldn't be a muscle that you would miss. Okay, so the key function of the supraspinatus is to stop the humeral escape. When the muscles are pulling it closer, that says the infraspinatus and the subscap, then it goes up, and if it goes up, the supraspinatus puts it down, and therefore the supraspinatus is the key muscle to putting the ball back into the socket. And if the round ball is in the round socket, then it will have functionally, you will have all the possible ways of functioning of the shoulder. So the shoulder key muscle is the supraspinatus. Down that way. Okay. So once we know that, can you guys mute? You know, there's a lot of family background. It's upsetting everybody. So can you mute if you're not talking? Okay. So this is the supraspinatus, infraspinatus, teres minor, subscap. The bicep also comes into the function of the rotator cuff, but we'll go that into in minutes. So why are we not moving now? Okay. So the most important thing to understand is that the shoulder joint is a very unstable joint, and the stability is improved by making the socket hollow and making a rim around it, such as the Bankart. But we'll go to stability some of the time. But today, we just want to know that it's a very, very difficult joint. And the cuff works as a dynamic stabilizer, as we've all said. So the supraspinatus is superior anterior, and the infraspinatus is posterior inferior. Okay, and that's what will happen, or what we need to know when we're doing transfers. Okay, which replaces what. But the function of the supraspinatus is key. It puts the ball back into the socket. Okay, you must all understand that. Okay, why am I not doing? Okay, so what tears the cuff? I've answered it up there, but what will cause a tear in the cuff? Do you know the indication or the pathology for what causes tear? The commonest cause is old age, attrition, and rubbing against the tendon and the shape of the tendon of the acromion. Yeah. Sometimes trauma does it, and sometimes some metabolic disorders will do it. But the commonest cause is impingement. Starts with impingement. There's two types of acromion: 1, 2, and 3. According to classification, flat, curved, and hooked. And the more it rubs, the more it causes tearing. Okay. The commonest cause is impingement with rubbing and aging. So by the time you're 40, if you're a type 2 acromion, will present. And my computer is going up today. Doesn't want to move. Okay. So if you look at it, this is what we were just talking about. Yeah. You have forces that pulls the shoulder or humerus to the shoulder or the glenoid and allows it to do a function. But if there was no stopping it, it will go and escape at the top. So the supraspinatus works out and causes problem. Well, do you know what is the difference, the acromio-humeral distance? Do you know anybody what is a normal acromio-humeral distance?
Usually around 4 to 5 millimeters.
That's abnormal. So 4 to 5 is abnormal. What's normal?
7.
10. Anything above 10 is normal. Okay? Anything below the 10 and the tendon is now thinning. That's how we know. And does anybody know the Hamada classification? No. Okay.
No, sir.
So this is the Hamada classification. Okay? The whole department of orthopedics, Faisalabad, is wanting to come in. Apparently, this is anyway. So this should be 10 millimeters, which is normal. Okay, this distance. When this distance is less than 10 millimeters, then you are getting to a stage where the tendon is thinning or going to tear, and that would be a Hamada 1. Okay. So when it becomes less than 5, but more than 3, then it becomes a 2. In a 3, it started saucerizing in the acromion. Okay. In 4, there is arthritis with the saucerization of the acromion, and in 5, there is total deformity of the joint. Okay, so the Hamada classification is important because why do we want to know this?
Guide management.
Yes. So if you have no arthritis, but humerus going high up, then you can still repair the cuff if it is repairable. Okay. Now, if you have arthritis into your joints, then there is no way that you can repair the soft tissue because you've gone beyond repair, you've gone beyond redemption. You need to now sort out the joint, because if you don't sort out the joint, repairing the cuff is not going to give you function. So if you have a joint like this or a joint like that, you cannot see the function if you cuff repaired. So your Hamada classification will help you in deciding whether this needs soft tissue correction or this needs an arthroplasty or something else. Okay, so the Hamada classification, the first thing you have to understand and learn is the acromial humeral distance, how it is, when it source rises, and when it's arthritic. These are the important changes. Up to that stage, you can do a repair. Sometimes you may not be able to bring the soft tissue cuff together, so you're augmented in something, but up to that stage, you can do soft tissue reconstruction to repair. But at this stage, you have to do something else. Okay? Any questions so far?
No, sir, thank you.
Yeah, okay. It's important to know this classification for you to decide when you want to do it. And this is an X-ray classification. You can see that it's the Hamada Fukuda classification, but everybody remembers it's an Hamada. So in the first stage, less than 10 but more than 5 millimeters, less than 5 millimeters, touching the acromion, and in 4A and B, arthritis sets in, and in 5, it is totally deformity, and therefore you have to do more than just a normal arthropathia, normal arthritis. Okay. So I'm sorry, I just have to admit people into it. I've never had this before. Normally this joined, but I don't think this is something new in. Okay. Right. So what are the symptoms of cuffed head? How will the patient come and present to you? If you're doing a short case or a long case, what will the patient tell you? Come on, guys. The sooner you answer, the sooner we can move on. So they have pain.
Come with pain.
They have pain.
They would have a restricted range of motion.
Very good.
Inability to overhead abduction, like combing or
sorry?
Overhead abduction exercise.
So there are different muscles doing different things. But the first thing is, because supraspinatus is the commonest one that goes away, lads, and say they cannot do any function at all. What will happen if they start to do anything? So tell me what will happen if they start doing anything. We just discussed this in anatomy. So if you start moving, the supraspinatus is not there. Infraspinatus and subscap will try to stabilize the shoulder, and when it does, it will escape up, which means that humerus hits the acromion, so it hikes it and it's painful. So they can't do any movement or function at all because the supraspinatus is not working. Okay? So the first function is stiffness, cannot do or move, cannot lie on the side, and there is crepitus, a lot of bone, touching bone. This is where the humeral head hikes into the acromion. Okay. So when you have a patient with a short case or a long case of what looks like a cuff tear, you need to take a detailed history. The detailed history would include, the age of the patient, because we know that a type 2 acromion will present by the time they're 40, and therefore they will start rubbing into the cuff. The type 3 acromion will present early. You need to assess them generally, and then there are special tests you need to do for the cuff. Does anybody know what are the special tests we're doing for the cuff assessment?
Yes, one is the Neus test.
So what's a Neus test? You've just said Neus test, but you have to tell me correctly what a Neus test is.
Painful range of motion along 160 to 120 degrees of shoulder abduction, and pain goes away after injection of the. So
it's key. The Neus sign is supraspinatus assessment in the line of the direction of the muscle, and if you inject it and the pain goes away, it becomes a Neus test. So in examination, we will do active and passive range of motion. Special tests will be for the supraspinatus, infraspinatus, teres minor, subscap, and biceps. So you don't need any test if you know how to examine these patients, like I said. Okay, so this is just a summary of a picture of what different type of tears present. The commonest is supraspinatus, and the tear is around the deltoid area, going to the side of the arm. Most often they will tell you that my biceps hurts, because in my country or in this part of the world, they all go to the internet and read and tell you that my biceps hurting, but it's not the bicep. The supraspinatus actually radiates to that side. The infraspinatus is slightly different. Subscap is more medial, and teres minor is also, very distal to the femoral head. But these are the type of patient's pain that will present itself if you're giving a history or taking a history of a cuff tear. You need to understand that everything is not supraspinatus. So the neck will radiate, heart will radiate, irritation of the diaphragm will radiate, the thoracic outlet syndrome will also radiate, a gallbladder problem will also radiate, and soft regional parent syndrome will also present itself in that particular type of pain. Okay, so it's not just cuff tear, but if you exclude all these by exclusion, then you know it's a cuff tear. Okay, so you examine by inspection, palpation, range of motion, strengthening tests, and spatial tests. I'm sure you know all these, so there's no point because you're doing exams on Monday, but I will tell you the special test, okay, how to inspect, rate, palpate, how to compare. You need to compare the range of motion. You need to look at scapulo-thoracic rhythm. You need to see from the back when the scapula starts moving. Is it the same time or is it early? If it's early, that means your glenohumeral joint is not working, so the scapula is trying to help it. Because for every 3 degrees, 1 degree comes from the scapula. And if the scapula is helping earlier than normal, that means the glenohumeral joint is not moving, so you have a stiff shoulder. These are all basics. Okay. So this is a supraspinatus stress test. Okay. And what you do is 30 degrees in the angle of the supraspinatus tendon. You allow the arm to point with the thumb down. Once the thumb is down, you put your hand on where the supraspinatus fossa is and ask them to resist or lift against resistance. You will feel the supraspinatus contract, and you will also feel pain if it is impinging. Okay, so the supraspinatus function is tested by the supraspinatus test. Again, it is in 30 degrees in the forward plane in the direction of the scapula, putting a hand on the wrist to stop it from elevating and to check for the contraction of the supraspinatus muscle. So this is supraspinatus test. Okay, are we clear with this?
Yes, sir.
So the next thing you do is the common external rotators. Okay, so this is the supraspinatus test being continued, where we're now trying to look at power by asking them to lift it from as low as to high, but the same test here. So next thing you do is after the supraspinatus, you ask the person to 90-90 and externally rotate against your hand. This is, if there is no difference, no problem, no pain, then your infraspinatus and teres minor are okay. If there is weakness or pain in external rotation against resistance, then the culprit is infraspinatus and teres minor. So how are you going to check for infraspinatus and teres minor?
Infraspinatus checked with arm to side, and teres minor is checked with 90 degree of abduction and external.
Okay, so you need to tell me the real deal, not just that this is an exam. So what's happened is in the infraspinatus, it is called the drop arm sign or extension rotation lag sign, okay? And for the teres minor, it's the Hund-Lowe's test. Agreed? Have you heard of the Hund-Lowe's test?
Yes, sir.
Okay, so this is the Hund-Lowe's test. Internal rotation in abduction is teres minor. Okay, internal rotation in abduction. Internal rotation in abduction. And external rotation in abduction is infraspinatus. That's how you differentiate between the two external rotators. Okay, so in a Hund-Lowe's sign, when the teres minor is not working, you won't be able to do this. So you'll have to lift his arm out to bring it to his face. And an extension rotation lag sign or a drop arm sign is when you put it in that position as an abduction and external rotation. If you let it go, the arm will fall because the infraspinatus is not working. It's called the drop arm sign or the extension rotation lag sign. Okay, so you do external rotation against resistance. If you find nothing wrong with it, then you don't have to do these tests. You know the infraspinatus and teres minor is okay. But if you find weakness, then you will separate the two muscles by doing a Hund-Lowe's to exclude teres minor and extension rotation lag sign to exclude infraspinatus. Everybody clear so far? So for special test, we do supraspinatus first, and then external rotation against resistance, then infraspinatus teres minor, okay? Then the subscap. And the subscap has got 3 different ways of doing it. You cannot do a Napoleon sign or, lift-off sign at the back because they're so painful they can't go there. So the easiest thing is to put the arm on the belly, right, and ask them to keep it there. And then what you do is you push the elbow down. And if the subscap is working, it won't allow you to push the elbow down. But if the subscap is not working, the elbow will fall down, as you can see from this picture, that the elbow is fallen down to do what you want it to do, okay? So now you know the subscap. There is another Gerber's lift-off test and various other tests to do. But the easier, you must remember one test in the exam, do one test so it shows your fluency. So if I was asked to do the cuff assessment, I would do the supraspinatus first by, doing it in 30 degrees, thumb pointing down, lifting against resistance. Once I've done the supraspinatus, I will then ask the person to do extension rotation against resistance. If it's fine, I'll say the external rotators are fine. If not, then I'll do the horn blowers or the extension rotators, like trying to tell which one is not working. It's normally the infraspinators. And then finally, to assess the subscap by the lift-off test, where you put the hand on the belly, or the belly press test, push the elbow down against resistance, and if there is no resistance, subscap is not working. Okay? Yes? No?
Yes, sir. Got
So
it.
what test is this? Final test of the special test. What test is this?
Speed test?
Very good. Why do you sound so confused? Yeah, it is the speed test. You're assessing biceps tendon.
Yes.
Okay, so the hand is in full extension, and you ask the person to lift his hand up against resistance. If there's pain, the bicep tendon at the glenohumeral joint is in trouble, and this is called a speed test. And you do this test to assess the cuff function and complete it, because the bicep tendon is very important in cuff management. Because if the subscap is torn, then you need to pay attention to the bicep tendon before you can actually repair the subscap. Yeah? Okay. So are we clear with the special test on the cuff now? Everybody's happy?
Sir, would you please kindly repeat the horn blower test once?
Which one?
The horn blower test.
Yeah. Okay. So if we go, so this is the first thing you do. They're both external rotators. We agree on that? They're both external rotators. Yes. So
Yes,
with the arm 90, abduct it to the body and flex at the elbow, mid pronation. You ask them to external rotate, right? So they are external rotators, and if there is no weakness, then they're fine. But if there is weakness or pain, then one of the two are going, the infraspinatus or teres minus. Okay. So for infraspinatus, it's abduction and external rotation. For teres minor, it's abduction but in internal rotation. Do you get that? Differences between rotation, whether it's internal or external rotation.
Okay, for teres minor, it's internal rotation.
Yes, it's called the horn blower. You can see the man is trying to blow a horn. Can you see it?
Yeah, I understand.
Okay. So we're going back now. Yeah, so if you look at it, it's blowing a horn, right?
Mm-hmm.
So internal rotation and abduction, but if you can't do that, well, our computer's playing up today, so I don't know what the reason for that. So when you look at it, he cannot blow his horn. So therefore, he's trying to internally rotate and bring it up to bring it to the mouth. It's not like that, okay? So
right.
teres minor is normally not gone. So this is a very rare finding. It may have a massive test, but it's very rare. Normally you see the supraspinatus and the infraspinatus, yeah? The infraspinatus is abduction and external rotation, which means it's called the extension rotation lag sign, which they try to hold the arm, but they can't, it just falls down, all right? Or it's the drop off side. So it's again 90, you leave it, it'll fall down, okay?
Right,
Infraspinatus and teres minor.
Thank you, sir, understood.
Subscap now, and there's the biceps test. Okay. Funny computer today. So how do you investigate them? You investigate every orthopedic thing with basically X-ray, ultrasound, CT scan, and MRI. Now, in my practice, I do a lot of X-rays and ultrasound. I don't do much CT scan. If I was to do MRI scan, I will do an MR arthrogram only and only if I was dealing with a Bankart lesion where I want to know whether I need to do a soft tissue repair, Bankart repair, or a lacerate. So most of my investigation is related to these top two. Okay, so this is saying that an MRI scan of a rotator cuff tech. Okay, so if you look at this black shadow, it comes down to the tuberosity, which means the tendon is intact. Okay, so what is N-isometry in X-rays, ultrasound, and MRI scan? Do you know what that means?
No, sir, we don't.
If the fibers are parallel to the rays, yeah, you will see them. If they're not parallel to the rays, you won't see them. So it will give you a pseudo appearance of a tear, but it's not there. So that means you have to change the position. And that's why you do multiple pictures and multiple levels to understand. But this is an intact cuff, and that's a torn cuff where the cuff is retracted. And that much is the retraction, probably about 5 centimeters, yeah? Okay. So this is what I do. This is my practice. We have a mobile ultrasound which attaches to my telephone, and we look at the cuff and diagnose what is wrong with the cuff, yeah? So that's what our cuff can look like. This is humeral head, supraspinatus. This is back tissue, this is deltoid and skin, deltoid and skin. So this is what I do. I can very easily now guide, inject, and assess, or supraspinatus, infraspinatus, teres minor, all those within ultrasound. Okay, so once you've diagnosed that you have a tear, then you need to know what classification you know. The commonest one is the Habermeyer classification, which is an anatomical classification. So you can have a tear in zone A, zone B, or zone C. And zone A is going to be subscap, zone B is going to be supraspinatus, and zone C is going to be infraspinatus and teres minor. Okay, so you have an anterior superior, or an anterior superior, and a posterior inferior. These are all anatomical classification of a position or localization of a cuff tear, and it's called the Habermeyer. So now you know anatomy, you need to know where the tear is, and you also then need to know whether you can repair it or not. And the easiest way to know is how much of a tear is there and how much retracted it is. Okay, and that's the Caulfield classification. So these are two classifications you have to remember for your exam: the Habermeyer and the Caulfield. A less than a centimeter tear from the margin of the tuberosity, less than a centimeter is one or small, then up to 3 centimeters medium, and up to 5 centimeters a large tear. You can repair up to large tears. Okay, depends on how long they are and how much of symptoms they have and what is the quality of the cuff. But just 5 centimeters is about the normal limits. Anything beyond 5 centimeters you can repair, but the evidence suggests that they don't hold them, they have got a very high failure rate. So you need to know where the tear is, so whether it's in the supraspinatus, infraspinatus, or subscap, and then you need to know how big the tear is to decide whether you can repair it or not. And when you're trying to repair it, you will do the what classification to see whether you can repair it or not. What classification? Come on, guys. What classification? You will do the Himada classification, because if there is arthritis, then you can't repair it. Even if you can repair it clinically, you can't repair it because you can't come on the floor. So you don't need to do an operation that you don't need to. So you need to know where the tear is, you need to know how big the tear is, and is there arthritis or not. These are the 3 important things before you decide you want to do something with the tear. Everybody happy with that?
Yes, sir. Got it.
Okay. So the management for most tear is not surgery. In the exam, you will say that I will try a non-operative management first. If you don't, most examiners will fail you. Okay, you can't tell them that I've got a cuff tear and I will repair it, unless, of course, the cuff is got such a stage where it is a moderate tear and you want to do it as quickly as possible. But your management will always start with non-operative. So you give them rest, physio, some anti-inflammatory medication, and then injection therapy and steroids or PRPs. What does a steroid do in a shoulder in cuff tear?
Reducing inflammation.
An injection. So injection produces inflammation.
Not sure.
So all orthopods give injections to everybody. Why do we give injections?
Pain relief.
Sorry?
To relieve pain.
Yeah, so I can give you paracetamol as a relief pain. Why do I want to give you an injection?
Probably because it acts as a spacer. I'm not sure. Maybe it's a far-fetched thought.
The reason you give injection into a joint is for diagnostic purposes. Right? Only diagnostic purposes. You cannot do multiple injections or repeat injections, because injection has got steroid in it, and steroid is an anti-inflammatory, which means it stops the repair and healing process. So when you have an inflammatory process in the joint, the first thing that comes is help to repair it. Okay, and to help to repair it is the tumor necrosis factor alpha and various other hormones that brings other tissues to heal it. Now that causes pain, temperature in the local joint. By giving them steroid, you make them better. What is the role of steroids in COVID times, in coronavirus times? What is the role of it? What happens in steroids in coronavirus? So can you give steroids in coronavirus times?
Some institutes do administer steroid intravenously. Also reduce inflammation.
What is the guidelines from the British Orthopedic Association on injecting steroids into joints during coronavirus times? So steroid causes decrease in immunity. So if you give steroid into coronavirus times, you have a higher than normal risk of getting coronavirus. So you have to be very, very clear on why you want to give steroids to patients in current medicine times. You can't just give steroids because it will decrease the immunity, and therefore there's a higher risk and chance of having a more fulminant or more aggressive coronavirus infection. Okay, so you must use steroids very carefully in coronavirus times. Okay. Did you guys not know that?
Specifically the British guidelines.
Sorry?
I didn't know specifically what the British guidelines
We have
said
been told here that we cannot use steroids. We use steroids with caution because if the person gets COVID, his inflammation will be very fulminant and will be very aggressive. So we don't give people steroids as we used to. We used to give them, for no reason at all. But now we're very careful. Anyway, it's a diagnostic test. You don't have to give it for pain relief. Okay. So if you look at the literature, the non-operative treatment for cuff tears is up to 92% good. Okay, we can respond to physiotherapy and management up to 92% of the time. Okay, and they can have good outcome for 24 months. The unfavorable reports are if you have a tear which is big, if you have symptoms for a year, and if you have function that's not happening. Okay, so these are the indications of surgery basically. Okay, so but you must talk about non-operative management before you do anything in every operation or every procedure or every case you see. Okay, so this is called a toe repair. Do you know what is a toe repair? This is a cuff repair, but it's called a toe repair. Guys, you're doing an exam in 2 days' time. This is basics of cuff repair. It's called transosseous equivalent repair. Okay, in older times, they used to make a hole into the humeral tuberosity, and the cuff used to be stitched in such a way that it used to go through the hole and connect on the other side and hold it together. But now we don't do that. We use anchors to put it down, and therefore it becomes a transosseous equivalent or a toe repair. Okay, so we're not making holes, but we're making a double row repair. In a double row, the medial side is brought down to touch the tuberosity, which is roughened, which is like a core suture of a tendon, and the other suture is the running suture to allow it to go flat to give you movement. So you put anchors, get the edge, and close it together in a fashion in a double row repair, and it's called transosseous equivalent repair or a toe repair. Okay, this is the basic cuff repair. Now, if you have a massive cuff tear, which is greater than 5 centimeters, then evidence supports that even if you get a good repair, this is not going to work for you and it's going to fail. So when you have a big repair like that, then the word to use for them is irreparable tears. Okay? And for an irreparable tear, you go back to what classification?
I don't want to play, man. Calm down. Calm
Sorry?
down. I've told you 3 times now.
Sorry?
Oh, look. आप भी जरा break दें थोड़ी देर.
Okay. So paying attention to this is a massive cuff tear, yeah? It is more than 5 centimeters gap between the tuberosity and the cuff. So what classification are you use now to decide what you want to do here?
Hamada classification.
You will use the Hamada classification. If there is no arthritis, then you will attempt to augment this or replace this or put something in it to repair it or give the functional cuff. But if there is arthritis, then you will, depending on the age of the patient, move on to arthroplasty. Okay? So the clear demarcation is 5 centimeters. If you have a 5 centimeter or more tear, if you repair it, it will still not work. So we call it a massive tear or irreparable tear. Okay? So there, the tear size is the main predictor of failure. And also it depends on quality, timing from surgery, and age. But the Chinese paper that says that if it's 5 centimeters or more, the person is very old, the tissue quality is not very good, and the time to surgery, i.e. from where the symptoms is to when the surgery is done more than a year later, it will not get a good outcome. Okay, so you need to make sure that you repair the ones which have a good outcome rather than everything that comes into the door. Okay, so what classification is this now? So we do an MRI
Cofield classification?
Sorry?
Cofield one?
No. So this is a classification which looks at supraspinatus, infraspinatus on an MRI scan. So there's a supraspinatus, infraspinatus, and teres minor. Okay. So if you have to repair them, the cuff should be normal on an MRI scan. So this is a normal cuff. If it becomes flat, it is just about repairable because the cuff is going into atrophy. Okay. And if it's beyond the hollow or beyond the straight line, then it is not repairable. That means there is more fat and degeneration in it. Whatever you're going to do, it's not going to stay. So you need to look at an MRI scan to see what the state of the cuff is. Okay. We've just discussed that, isn't it? Yeah. So this is what actually happens in an irreparable cuff. The cuff is like a bridge which holds everything together, and as soon as it becomes irreparable, it will fall down, and therefore it won't support the humerus, and therefore it will go higher. Okay, and when it goes high up, the first thing it's going to affect is what? So what goes through here?
The
biceps tendon.
bicep
So
tendon, yes.
if your force couple is gone, the biceps tendon detaches itself, and that's why you need to assess the biceps tendon to know how bad the tear is, whether it's pulling on the biceps or not. Okay, the biceps will pull, and once the biceps pull, the subscap will attach very near to it, and the subscap will tear, and then you will have muscle atrophy. So just by having a supraspinatus tear, it triggers a sequence of events where from the supraspinatus it takes the biceps, and from the biceps it takes the subscap, and then it becomes a massive tear, an irreparable tear. Okay, but the force couple goes. This is what you need to understand. The subscap is a bit that's putting the ball back into the socket. So it's not as easy as we all thought, and it's a lot complicated. Okay, so the most important irreparable tears are the posterior inferior cuffs. Okay, and you have a positive Hornblower sign, and there is MRI will show, and we showed you the MRI scan earlier, that it will show that it is a fatty infiltrated and retracted. Okay, so you can try your best, you can pull it down, but it won't work. So what do we do with these cases? So if you have got a Hemata 3, no arthritis, in irreparable care, what are your options then?
Tendon transfers.
Yes. What else?
And then graft.
You can do a
Synthetic
graft.
grafts.
You can do various grafts. You can do an artificial graft, or you can do an allograft, or you can do an autograft. Most common autograft used is tensor fascial lata. Okay.
Yeah.
So the first person who started talking about grafts was a Japanese person, and he started putting tensor fascial lata in the defects. He used to stitch them to the glenoid and to the tuberosity. Later on, an artificial graft was replaced in it. You can also put a spacer in there, which is a balloon which pushes it mechanically to allow the ball back into the socket, which means that the rest of the muscles can move the shoulder. Or you can use the biceps tendon if it's intact to cover the defect. Okay, and the most commonest and most successful outcome for these is with tendon transfers. So if you have an anterior superior problem, then you do a pec major transfer. If you have a posterior inferior problem, then you do a lateral side transfer. Is that clear?
Yes, sir, that's clear.
So
Yes,
if you
sir.
have no arthritis but an irreparable cuff, you either graft it, tendon replace it, or do fancy things that they do in Europe, is put balloon in there, or a artificial graft. Okay, I think I've got a picture of that somewhere. So this is an MRI scan showing fat infiltration and retraction, all that kind of stuff. Okay, they have pain and function, and the ball is not in the socket, so it moves high up, which is called a superior migration, and therefore you've got pain. So you have to, there is no arthritis here, so you need to do something to bring it down. Okay, again, the Hemata classification, you can put a balloon in there, but balloon mechanically puts the ball back into the socket, and by doing that, the rest of the muscle, especially the deltoid, functions. You can see how it is. This is the deltoid, how it makes a deltoid function, and you can have abduction, extension, and flexion. Or you can replace the joint, but if you're very young, you can't do this. So you have to be age specific for this by reversing the mechanics. So the goal here is joint preservation. So this is the first one, which is called an SCR, superior capsular reconstruction. Initially, it was the TFCC. It was the fascial lata, tensor fascial lata. But later on, an artificial graft was used. There's a balloon you can mechanically put in there, or you can use the biceps tendon to connect the tendon to the tuberosity to give it some support to stop it from going up, right? And this is only to do it until the patient gets arthritic and is old enough to have a joint replacement, or you can put the biceps tendon across. So in the exam, you need to do the Hemata classification, and if there is no arthritis, then you will either do a tensor fascial lata graft, or you will do a graft from the lat dorsi and from pec major in the exam, because none of the examiners will know this. So to talk about this, you might get into trouble. But you can say you need to mechanically push the humerus back into the glenoid to make the exam. Okay. These are some of the patients that we did, which is a balloon. So this person had about 7 millimeter and became 8 millimeters after you put a balloon in and the pain function gone. Yeah, sadly, this person had arthritis, where they had to do more things for him anyway in the future. I think this is one of my patients. This had got a balloon put in. So you can see, sideways. Yeah, this is the one we put the balloon in. He's doing really well, and this one not so well, but okay. You can see that that's the arm that's got the balloon in. So he was a model 3. That's why we decided to do a soft tissue procedure for him. Okay. This is something coming new. If you have an intrasubstance tear, then you can either repair it and then inject it, or they repair it and then augment it with an injection. So this is called PRP, platelet-rich plasma. There's no role of platelet-rich plasma in cuff tears, but a new variant, a new modification, which is called tender ACP, which has got a collagen scaffold, which allows the graft to fill with the collagen, and then the PRP heals it. And this is also what we do. This is a repair, and we're injecting with this needle PRP, tender ACP into the cuff. Okay, and that's lattice muscular transfer for posterior inferior tears. You bring this, take it off, and put it up. The limiting factor is the vascular supply. And for the anterior superior tears, you do the pec major transfers. Yeah. Okay. So we're happy with soft tissue transfers, how to assess and clinically examine the cuff, make a diagnosis, find out which one is tore, which function is missing, what can you do. We need to know whether the cuff is good enough to be repaired or not. And if it's not good enough to be repaired, we need to know whether there's arthritis or not. If there is no arthritis, we can do tendon transfers, because for a tendon transfer, you have to have a normal joint. If there is arthritis, then there are other things we can do for it. Are we happy so far? Yes? No?
Yes, sir. Yes. Happy.
This is clear now, yeah? So if anybody asks you about a cuff tear and management for soft tissue, up to now, you will be okay.
Pretty much, yes.
Quite a lot of new concepts for you guys to remember, but that's what it takes. This is what cuff tear is all about. Okay, this is the most important classification to understand. Centering of the ball, you need to know if it's arthritic or not. Okay, so the next stage is now you're in the right age, you're 65 plus. Sorry, before I go there, what is the age to do an arthroplasty in a person? Does anybody know what age can you offer somebody arthroplasty? So there is no age limit for rheumatoid and tumor patients and infections, okay? However, if you want to give this to a normal person who has got no other comorbidities, then your life expectancy minus 10 years is the age. So the life expectancy for Pakistan is 65. So you can offer them a joint replacement from 50 years onwards. Okay? Everybody's gone quiet. Everybody's gone very quiet. Yes, no? Hello?
Yes, sir, we can hear you.
Yeah, I just would want, do you understand so far, yeah?
Yes, sir. Yes.
Pakistan is losing to England. They've got 38 runs left anyway, okay. Right. So this is now when you have a cough and you're in the right age and you've gone into Hamada 4 and 5, then you need to do a joint replacement. So what does the reverse do? What is the key function of the reverse shoulder? Why are we not offering plain arthroplasty? Why are we only offering reverse shoulder here? Does anybody understand the biomechanics? Why are we doing a reverse here?
The push of the center of gravity medially, and the function will be taken over by the
but the initial reverse was always medial. The normal reverses these days are never medial. I'll show it to you in a minute now, okay? But that was the first reverse design that pushed everything medially. But the whole idea for the reverse is to tension the deltoid. So the deltoid function, okay? Don't talk about medial and lateral because we get into trouble, because the old one, which was the old American reverses, they were all medial, but by doing medial, they were all notching and they were causing problems. So then they lateralized everything. By doing that, the glenoid became loose because the force of it was too far. So now the center of rotation is where it is, but the humerus lateralized, which makes the deltoid stretch. And therefore, the key answer to this, the reverse, is done to stretch the deltoid to allow you to have function, because when the deltoid is stretched at tension, then it will give you abduction, extension, and flexion. Yeah. So that's only if you have a no cuff, and you're arthritic in the shoulder. Okay, an irreparable cuff and an arthritis. We're happy with this so far? You understand the indication for reverse? When you have no cuff and you have irreparable cuff, and you have arthritis, so Hamada 4 and a 5, yes? And you do it to tension the deltoid so that the deltoid can give you abduction, flexion, and extension. The cuff doesn't work anymore. The mechanics put the ball back into the socket, and the round bit is where it should be, and therefore the deltoid gives you function. So the reverse is for the deltoid to give you function.
Yes.
So what have we got option-wise? So we've done cuff now. Okay, now we're going to arthroplasty. So any questions on cuff so far? Or if you're getting bored, we can stop. I don't mind. What do you want to do? We continue? No.
Yes, continue.
Okay, so this is now arthroplasty, and you're okay with cuff. You don't want to ask any questions on cuff. I like an interactive section. You're not saying anything to me. Are we happy with the cuff so far, and we can move to arthroplasty?
Yes, sir, we can proceed.
Okay. So in arthroplasty of the shoulder, like anything else, you have a hemi, which means half a shoulder. You have an anatomical, which means you're replacing anatomy, or you have a reverse, where you're replacing the anatomy by reversing it with your options. Okay? So the indication of hemi first. Before you know the indication of the hemi, you need to know this classification of the glenoid, which is called the Gillies classification. Right? Very nice man, I met him. He's very clever, he's a Frenchman. Okay, he works where, you know, Latager did his Latager's. He works in the same hospitals, and he's the person who's revived Latager's again, and he's done a lot of modifications to it. But he came up with a classification which has revolutionized the whole world. So you have an A1, A2, which means it is concentric. The humerus is still in the glenoid. And then you have a B1 and B2 where there is a biconcave, or it has gone posteriorly, or a C where there is no glenoid at all. Okay, so you need to know all these, because if that is not normal, your tissues around it is not normal, although you may have intact cuffs, but your function will not be there for your shoulder replacement. So this is a classification that you need to know by heart if you're talking about arthroplasty on the exam. Okay, the Gillies classification. Recently, the implants have now developed into becoming modular and planform and custom built implants. Okay, and endoprosthesis for tumor is not the topic of subject here, but you can actually replace the whole of the scapular joint with a hub and spoke hospital for special surgeons with unique patients. Okay, so let's come to hemi-shoulder transfer. So the young with trauma with AVN, you can give them hemi-shoulders. But what is the problem with the hemi-shoulder? Do you guys know? Has anybody seen a hemi-shoulder?
It tends to irritate the glenoid in the long term.
It does what?
It tends to irritate the glenoid
It
in
is
the
not
long
a
term.
question of irritating glenoids. There's no cuff. If the tuberosities are not fixed properly and there's no cuff. If there's no cuff, what's going to happen? Supraspinatus is not functioning. They will all migrate.
Migration.
Yes, they don't work. So you have to be very sure when you're trying to do a hemi-shoulder, especially in trauma. Okay? Because the tuberosity has to be fixed perfectly, otherwise they don't function. The tuberosity fracture is not a fracture, but a dysfunctioning supraspinatus. That's a very important part. So the whole world is going away from hemi, especially in trauma. Okay, so the indication of putting a hemi is in a B2 or a C glenoid. Okay, remember the Gillies classification? You can only put it in a B2 when there is no glenoid, where you want to articulate, or a C glenoid. What does that do? Sorry, I'm making it a bit more complicated, but you need to understand this concept here. So if you have a B2 or a C glenoid, what does that mean? There is no glenoid at all. It's either posterior deviated or none whatsoever. So why do you want to put a hemi here in an arthritic shoulder? So where's the articulation going to be when you put a hemi in these kind of glenoids? You have to say something. If you don't say anything at all, that means you were not listening. Then make a guess. Why do you want to put a hemi in a glenoid which is not existent? Nobody knows.
No idea, sir.
So the reason for that is that it articulates in the coracoacromial arch, not in the joint. Okay? So the articulation now is in the coracoacromial arch. So your humeral head is hemi and it will go high up. So you will have function, not perfect function, but you will have some function. The glenoid is not functioning anymore. So therefore you're not using the glenoid, but you're using the arch. So between the acromion, the coracoid, and the coracoacromial ligament, this is where it's going to articulate. Under the acromion and the front is, it stops it from coming out by the coracoacromial ligament. Therefore, they have function, but they wear out the acromion, and soon you have to do something for it, but it buys you 4 or 5 years. And that is why some of these hemi have got an extended articulating surface where they, instead of making a half head, they make a 3/4 head so that it articulates at the top. So the only idea of putting hemi in this indication is for it not to articulate in the joint, but articulate superiorly. Okay? So if you have a hemi and you want to operate, what do you do to the glenoid? You can do nothing to the glenoid, or you can what is called ream and run. Do you understand what ream and run means? You take a reamer and you take the cartilage off it. If you take the cartilage off it, there's a high chance it will go fibrous tissue on top of it. Therefore, you will have a normal looking glenoid with a cartilage, but not the real thing. Or you can do microfracture to allow it to heal. So it's the hemi you're replacing, but you do nothing to the glenoid. So for the glenoid, you can do nothing, reamer run, or do microfractures. Okay. Lately in Europe, in the youngs, they're using pyrocarbon hemi. Okay, a pyrocarbon hemi has got least resistance, therefore it doesn't wear the cartilage. And you can do this indication for people with glenoid or without glenoid. Okay, and this is what a pyrocarbon looks like. So that is what happens for a hemi. Very few indication. Not many people are doing hemis these days. For trauma, especially, it is a very, very big problem because they're all superior migrate. So they try to do something else now. But hemi indication would be if there is no glenoid, you want to articulate up here, or if you have a normal looking glenoid, but you want to change the articular surface, such as if you have APN or something like that, then you can replace the articular surface to allow it to heal. But very few indications for hemis these days now. So what are the indications for anatomic shoulder? This is when there is wear and tear of the shoulder and the cuff is intact. The cuff has to be intact. Okay, post-traumatic rheumatoid degenerative. And again, the Julie Walsh classification, you have to have an A1, A2, and a B1 glenoid. Do you remember what an A1 and A2 is? A concentric failure. So the glenoid is worn out, the humeral head still faces it, and the B1 that is partly eccentric but not posterior. So if you have an A1, A2, and a B1 glenoid, you can put an anatomical shoulder in there, and you have to have an intact functioning cuff. That is the key bit for it. Okay, and this is an arthritic shoulder. The glenoid looks okay, then it's concentric wear, and it has had an anatomical shoulder put in. Anatomical means you're replacing anatomy. For reverse shoulder, you have to have a cuff tear, or it has to be traumatic, which means that there is no function of the supraspinatus, or the glenoid is abnormal. Okay, so because the glenoid is abnormal, it doesn't stay in the center, therefore soft tissue balance is not there, and therefore you need to reverse the mechanics. And to reverse the mechanics, you're stretching the deltoid, and by stretching the deltoid, you get function. So the reverse is giving you function by stretching the deltoid. Okay, and this is what a reverse looks like. You can see it's gone really high up, irreparable. This is the right edge, so I have a reverse put in, and this is what it looks like. And this is one of my reverse that came in, which was arthritic, the one we just showed the x-rays. And this is the end result after reverse. You can see the deltoid is functioning very aggressively. They have sometimes problem with the acromial fractures also, because of the deltoid being stretched too much. You have to get the tension right. And this is my secretary, and she fell a few years ago, and this is what she did to herself. We put a reverse in there, and this is the function now. She's not perfect, but there's no pain, and she can do most things. Right, so this is a better result than putting hemi into pain damage. Okay. So techniques, how do you actually do a shoulder arthroplasty is you've decided there's no cuff, there is arthritis, it's a Marder 3 or 4, and you diagnose that, and the next thing is you do a delta pectoral approach. Okay, so I always do a delta pectoral. Why is that? Does anybody know why we all do delta pectoral approaches now? There are many new approaches, but delta pectoral is what we all do now, most of us, all the clever ones. Do you know why?
Can be extended superiorly as well as inferiorly.
Sorry?
Easily. Can be extended superiorly and inferiorly.
I can't hear you, but that probably is. The reason we do a deltoid approach is we have to preserve the deltoid because the deltoid helps in functioning the shoulder, right? So if you cut the deltoid in the middle, your deltoid function is lost, and whatever you're going to get from the deltoid is not going to happen. This phenomenon is called the deltoid wrap. The deltoid wraps around the humerus and tension, so therefore it helps the supraspinatus into abduction, flexion, and adduction, in extension, flexion, and abduction. This is a function of the deltoid. So if you do a deltopectoral approach, you preserve the deltoid, and you preserve the deltoid wrap, and then you preserve the deltoid tensioning, and therefore you have function out of the shoulder. Okay? So the deltopectoral approach is done because of these reasons, not because that's what we all do. It is done because the deltoid has to be saved at all costs. So you find the coracoid, and you find the AC joint, and you find the middle of the coracoid and the AC joint, and you drop that. The normal ones you talk about this, but I do a modification in the skin because if I have a vascular problem, I can go from this incision, or if I have to do a decompression, I can do with the same incision. But the normal incision is like that. My incision is different, but my approach is deltopectoral. Okay? So deltopectoral approach is what you have to talk in the exam, and the reason for that is deltoid wrap, deltoid tensioning, and therefore function of the deltoid. Okay, I always give some injection into the skin to allow a flame. Once I've cut the skin, oh come on. Yeah, so I use a deltoid because of deltoid wrap. This is no wrapping if you do an approach and deltoid does not function. But if you do approach and preserve the deltoid, the tuberosity will push the deltoid, tension it, and you have deltoid wrapping, tensioning, and function from the deltoid. This is the key development in the last 10 years on approaches to the shoulder, that the deltopectoral is the best approach to get to it. Okay, so now once I've cut the skin, I will find the clavipectoral fascia. And this is the coracoid, and this is the strap muscles. What is the famous saying about these? Do you know? So safe side and suicide. Everything on this side of the coracoid is safe, everything on that side is suicide. Okay, because all the brachial plexus is there. So what you do is you cut the coracoid. So you find the coracoid, you clear this clavipectoral fascia, and then you lift the strap muscles. When you lift the strap muscles, you're on the subscap. These are the lesion vessels you see, the subscap veins that are present up there. There are 3 of them that you can see. You have to tie them to make sure that they don't bleed when you're operating. Okay? Sorry. So the next stage is you tie the vessels, and then use a diaphragm or a knife to cut it off the neck. Once you do that, you extend and rotate. As you extend and rotate, it will all come off. Okay? And then you have to cut the biceps, because with the biceps you have no function. It will be in the way. You cut the biceps, but you put a stay suture on it. So when you're closing the wound, you put it in the wound so that you're able to have biceps functioning. This is called a biceps tenodesis, but it's done with the wound. The next thing is called circumcision. So you find the glenoid, and you put a retractor underneath it, and you 30 degrees of inner elevation of the shoulder of the body of the patient makes the glenoid in front of you, and you clean it, and this is called circumcision. Once you've done that, then you can do whatever arthroplasty method you want. This is fracture. In the fracture, you don't use the same approach. Okay, this is a deltopectoral approach. In a fracture, you use a deltopectoral approach up to the level of subscap. You don't cut the subscap. Okay, because if you cut the subscap, there's nothing to heal it. It's attached to the bone. So here, what you do is you open the gate. So this is the biceps tendon, and you split the tuberosities with the biceps tendon. So you have a greater tuberosity and a lesser tuberosity, and you open the door. When you open the door, this is what you open the door is. The humeral head will be in there. And once you take the humeral head out, you have the glenoid right in front of you. Okay? And when you're attaching it, the tuberosity management is key, because if your tuberosity is not perfect, then whatever you do is not going to work. Okay? So this is the greater and lesser tuberosity, and the joint's been put in, and then you close it on top of it to do tuberosity management. This will make your tuberosity work. So this is the final question. Is there a place of hemi in trauma? The answer to that is no, because this is what happens. This is one of my patients. Did really well, looks very good. Okay, but this is what happens. They fail because there is no supraspinatus, and the tuberosities don't heal well, and if they don't heal well, they all fail. Okay, and there's a lot of evidence to suggest that in the elderly, if you have a tuberosity fracture, you should do a reverse rather than do a hemi. Okay, question time. I think we've covered a lot of difficult things in a very short time. I'm not sure how much you understood, but now's the time to ask questions so we can understand what we discussed.
Sir, in young patient with a comminuted fracture of the proximal traumatic patient, sir, with massive combination of the humeral head, can we use the hemi in a young labor patient?
So when it's a non-reconstructible position, it becomes very difficult. Okay, whatever you're going to do, you can use a hemi, but if you use a hemi, then you will be prepared to do a revision. The younger you use it, the more easy it's going to be more difficult it's going to be because it's going to be needing to revise. However, it is about tuberosity management. Young, old, man, woman. If your tuberosity management is fine, it'll buy you 5 years, 6 years, maybe 10 years if you're very lucky. But if your tuberosity management is not right, just putting a hemi is not going to bail you out. So you can put a hemi in a young person with an irreconstructible humeral head. However, you need to make sure your tuberosity management is good. So your tuberosity should be where it should be. It should be bone graft put in there. It should be prepared in such a way that it doesn't migrate and allows you to supraspinatus cover and function. So yes, the answer to that is you can put a hemi in a young person if you cannot reconstruct the head. However, if you are in that situation, you have to do the tuberosity repair well. The other option is to repair the whole thing as much as you can and put a plate onto it and attach everything to a plate. It will get AVM. It will die, but the dying will buy you about 5 or 6 years. You have got no joint, you repaired it with a plate, and you can end up having some life. So you see how you feel. If you can't repair it and you have no other choice, you can put a hemi, but your reconstruction and management of your tuberosity is vital. Does that answer your question?
Yes, sir. Thank you very much, sir.
Dr. Is there a role for shoulder arthrodesis in a patient with
I can't hear you.
arthritis?
Is it Qasim? I can't hear you, Qasim. You're breaking up.
So I was asking, is there a role for shoulder arthrodesis in a patient with
Sorry, is there a role of what, sorry?
shoulder arthrodesis?
Yes, in the younger person, you can do a shoulder arthrodesis. The only problem is that with hip replacement, an arthrodesis can be converted into a hip replacement in the future. With a shoulder, an arthrodesis cannot be converted into a shoulder replacement in the future.
Right, sir. Thank you.
No more questions. Is that it? Should we call it a day?
Thank you, sir.
Thank you, sir.
Okay.